We are excited to have Dr. David Williams, Ontario Chief Medical Officer of Health, on the call with us today. Dr. Williams is currently the Chief Medical Officer of Health for the province of Ontario and the executive lead of the Office of the Chief Medical Officer of Health, Public Health Division at the Ministry of Health and Long-Term Care. Dr. Williams assumes the interim Chief Medical Officer of Health position on July 1st, 2015, having been in the position of Medical Officer of Health for the Thunder Bay District Board of Health from October 2011 to June 2015. Welcome, Dr. Williams.
Good morning, Heather.
Good morning. We were so excited to see the Connected Communities Healthier Together when it was published in February. These reports that are published by the Chief Medical Officers of Health across Canada. Can you talk about the purpose of these annual reports?
Well, thank you. The annual reports are an integral part of the role of the Chief Medical Officer of Health in the province of Ontario. A number of years ago, supporting the independent role or the quality independent role of the Chief Medical Officer of Health is the requirement of the Medical Officer of Health to at least annually submit a report to the legislature and on the health of the public or the public health. And the topic can be selected by the Chief Medical Officer of Health. So legislatively, I'm required to issue a report, and that's a great opportunity to raise awareness of issues of concern to the legislature and via that to the public writ large in that, as well as the wider public health sector and other sectors within the province of Ontario.
That's great. What led your office to focus on the role of community connection to promote positive health outcomes?
Well, that's a good question because we have been looking at a number of issues of public health in Ontario and we're trying to raise the issue. As you will note, if some do have copies of the report in there, and for those who can see online, I do have my copy here in front of me, and I'll show that to you. And there's an insert in the middle of the report or electronically that evidence or supports the last two reports prior to this one as well, because we have been looking at the aspect of in our public and our public health, while we do have vertical programs and we carry out various initiatives to deal with health protection, and we've looked at issues historically over a long time around chronic disease prevention, dealing with aspects of various priority populations, vulnerable populations, health inequity, and as well as looking at marginalized populations within our sector. And it's become aware to us that some of our aspects related to the community side have been needing more attention to be looked at. And as we looked into it, we found more and more support for that. And so when we picked this topic, which is the third phase of our other ones, this one was talking about how are people not connected in community. And we have looked at the data, and it was very overwhelming to hear that people in isolation, and you've heard evidence from other countries such as the UK, where they've actually put in a minister of loneliness in that role, and others are realizing that this is in fact a very important matter, and loneliness itself is, as we say in there, is equivalent, the health risk is equivalent to smoking 15 cigarettes a day, with social isolation being the same standard. So it's not a benign issue and not one that we need to ignore, because for a while I feel we have ignored the problem because often that isolated person is in isolation. We do not hear from them. They're the silent voice out there that is someone in need of. So how do we raise that profile? And that's why we took this look at this community. We talked about first community data and the lack of quality data therein. Then we looked at actually groups that are becoming more and more isolated within our societies because of the way our societies are structuring, are changing, are shifting, our economic factors that are impacting that. And as a result, we're getting more and more individuals becoming isolated. And so from our second paper, which we're going to ask some questions about in a moment, we look at some other priorities in there dealing with health equity, and not just as an interest point, but as a real urgency to address it in a tight and functional way. This one here talks about how do we get people connected in community, the value of being connected in community, the role of community in connecting people, the role of governments, being provincial, municipal, and our local public health entities to encourage and deal with that connectivity. So it was really putting a pulse on that whole aspect around community. And what is our understanding, our lack of understanding, our data, our lack of data, and also our lack of tools or thinking about how we challenge ourselves. How should we address this issue in dealing with community connectivity? And so even on the front cover, if people have electronic copy, we tried to portray there aspects of that. For example, people may be connected in a local geographical area, as in a neighborhood. People may be connected by other things that may not be adjacent to each other, but they may be connected through various social connectivity, such as clubs, memberships, church, faith belief groups in that. So they may not be located near each other, but they may be connected nevertheless, or through large family, extended family circles. We try to represent on also that people may be connected, and this is a bit counterproductive to what the other things are, is that we've seen the evolution of social media. While people are more connected electronically than ever, they're more isolated than ever. And then we'd raise the question, can you be connected virtually in a very functional way? And we have not addressed that. As the technology has impacted our society, we have tended to take the negative side and people become more isolated. How do we take a handle on that? How do we say you can actually be virtually well connected? And some of our people out there are saying, that's like a contradiction in terms. But maybe it's because we have ignored it. We have not worked at it, certainly. We just assumed it was just going to happen. And in fact, it has not happened and has been more counterproductive. And we've seen impacts of that with people's health deteriorating, more evidence of people in isolation, even with our recent opioid issue and that. And we have different people that are isolated more and more, and we're trying to identify those. So that's why we got into this topic. That's why we felt it was important to bring it forward. And that's why we're very happy to have this opportunity to webinar. And a number of other groups, even outside the normal circle of the public health practice, have actually embraced it and said, this is finally what we've been waiting to hear, because we think this is a very important aspect that should have been talked about before. So this engaged discussion, which is part of the role of the CMH report, is not meant to be a comprehensive answer. It's to raise awareness, to raise the issue, in a sense, to start the discussions, because it raises the fact that we need to address this. How should we now go forward and address this issue? So my reports are not meant to be the final statement. More state, as we say, any problem, the first thing you have to ask yourself is, what is the problem? Do you know the questions? And then from there, how do we start to bring the conversation forward to deal with the discussions, to start to deal with the issue? And so where I'm very happy to be having this webinar with some number of people on there too, saying we want to be entering into the discussion.
That's great. Tamarack is really trying to build this movement around deepening community, and this report is definitely going to be one of our tools that we will use to raise awareness. So in the report, what are three major ideas that you want people to take from this report?
So that's it. And thank you for bringing that point forward. As you will see, if you do have the electronic version, or if you may be one of the few who got the hard copy, but we're trying to be modern in technology, you will see that in the middle of the report, there is a fold out of the three reports. I'm not going to try and hold it up in front of everybody, but if you see the three reports, the first one was called Mapping Wellness, Ontario's Route to Healthier Communities. One aspect that's become very apparent to me is that in our health status data, including our demographics and that, we're not granular enough to get down to the local community. We have done the sense of saying population health, if the provincial data looks good, everything must be good. And on our old model of the Rose population curve, if you move the whole bell curve over, everybody's getting better. It's become apparent to me and others that that may not be the right model shift. In fact, while we're moving the mean, the mode may not be moving. And in fact, we're moving the whole curve in some sense, but this tail is getting longer out the other end. In fact, there may be actually small bell curves behind with isolated populations that are hidden and ignored in the data. And we can't say to ourselves, well, because the average is getting better, that's all we got to do. And I don't think that's an adequate answer. So as we probe down to local data, and some have already done that, saying, in spite of your thing that the provincial indices are getting better, we would like to say in our area, and of course work done by others ahead of us, such as Corey Newdorf in the report in Saskatchewan and Saskatoon, have demonstrated that your overall population mean average may not be a good indicator and might be false sense of security, and that you need to now address these other ones. How do you do that if you don't have the data? What kind of data should you be looking at? Because when you start to go to these communities, we often go on saying, well, the data 5 years ago says this. They're going and saying, 5 years ago? Or the data in Burbank says this. What do you think? And they'll say, that's not us. So how are we going to engage communities if we have no data? It's not current. It doesn't apply to them. It doesn't give them a way that they can say, oh, this is us. This does make sense. And then how are you going to engage in a conversation to say, what would the community like to do about it? We weren't aware of this, and we'd like to know about it, but we'd like to be convinced that the data is authentic, it's real, it's appropriate, it's timely. And then how do we advance on that? So that was our first report. Our second report, following on some of the work earlier by groups such as Dr. Newdorf and team, have indicated that even within your community, you will have clusters of individuals, not talking about one or two, whole neighborhoods, and people might call it a new economic ghetto per se, that in the midst of our groups, we have people due to various isolations, lack of connectivity in that their health indices are not just slightly worse, they are significantly worse. And we're talking like 400 to 500%, even up to 900% difference in mortality and morbidity, right in the midst of our communities that on their overall data, things look very fine, thank you very much. Is that acceptable? In my mind, it's not acceptable.
Yeah.
And the fact is that in our protection services, we would say if you have an outbreak where the mortality is up by 5 or 10%, let alone 2 to 300%, you would say we need to act now. But what are the tools that we have to work with that? If we don't have them there, how should we respond to that? How should we deal with that? And it raises the issue around equity in that if we do not have the right tools and a right aspect for community development activity on an urgent basis, then we're missing the mark on this one. And so I'm saying from that standpoint, while we wait for the larger societal health equity issues, be it wage, be it income, and all other aspects there to be addressed by the political leadership, if we have these clusters of high-risk populations that have mortality and morbidity rates way above their fellow communities, let alone provincial and national levels, we cannot sit back and wait for the societal issues to get right. We need to act on them now. And we look at models where people have done that, and we say, we all need to be stepping forward. And finally, the last report from recommendations saying, if we're going to be interested in communities, as we go through the changes, our societal changes with large amounts of new population coming in from immigration, we have populations on the move, job, economic shifts, we have housing things that move people all around everywhere, we have lack of connectivity around the community side. How do we get an interest back in investing in community? Do you know your community? Do you know in some place? Do you know your neighbor? Do you care to know your neighbor? And why should you? And then what do we do to encourage that from a provincial standpoint? We talk about those environments and different aspects there. And how do things that we make decisions on high policy level that actually encourage community or actually discourage community? What do we do at the municipal level and decision making around buildings and structures and bus routes and that actually isolates people? Not maybe intentionally, maybe unintentionally, but we need to have that so that community in all type decision, not health equity in all, maybe we have to have community in all. And one of those things that we should put in there that do that from a public health practice standpoint. How do we do that? How do we work at those ones? How do we build up relationships and trust from a group that tends to be not connected, not trustful, not aware? And some of them, when we even talk about our hallway patients, most of them are, many of them are made up of individuals who are not connected with the primary healthcare system, do not attend the primary health system. So if you say we're just going to do harder primary care from a group that's distrustful, not sure, and not encouraged to access it, how do we get in there? How do we deal with that? So this is a challenge to public health writ large, to our communities writ large, to municipalities, their governments, and to our provincial government saying, how do we across the board put communities in all policies to encourage this, to bring people back into connectivity? So those are the recommendations that came out of those 3 reports and challenging all of us to say, how do you do it? And in those reports, there's many examples of groups that are already doing that. And so we're not walking in a vacuum. We have groups who have done excellent work on demonstrating various ways that you can go about and doing and approaching that. And we thank them for that. And we know that others are stepping up and starting to move in that direction. This is only about encouraging and important.
So having said that, we're going to move on to what are some of the policies and initiatives that that provincial and municipal governments can do to move forward the building of community to allow it to flourish?
Well, and that's one of the recommendations coming out of there. If we're going to try and do this, One of the first ones we said from our first report is that currently our data, our information on the social network, the social milieu, down to the community and neighborhood level is missing. And invest in those data collection systems, because you need, it's not just sloppy data, it's good data. How does one do that? One has to invest in that. And what's the value added of that investment? And also, how does one do it in such a way that it's, one, valuable, it's effective, it's efficient, it's also protecting people's individuality and privacy, and yet has enough granularity that the people in the community can say, that is us, that is our community. But they can't say in the data, say, oh, we know who that person is, and someone's privacy has been violated. So data is good both ways. And how does one do that in such a way that respects the community? Because some of the results may not be positive. And the community may say, well, while we'd like to know this, we don't like everybody else to know that. But if we're going to take it, we're going to take it and we're going to deal with the thing. So investing in those kind of systems is not without cost. And you have to do it not only with just buying it, you have to set up the infrastructure to get it, to obtain it, and because you have to do it again and again and again, because the community want to say, well, now 2 years later, have we moved the yardsticks? How are we doing? And 3 years later, and 5 years later. So what are those trend analysis you're going to do? So you have to do some consistency over time, because what our communities change, they don't actually change overnight, but they don't change like every 10 years. They change more frequent than that. So you have your frequency, your surveys, your information, your data points. As well as then, how do you realign your public health programs and services to be able and capable of addressing that? Some may not, we're not from Ontario on this webinar, but those who are from Ontario and have known that in our Ontario public standards, we took a fairly bold step now a year ago, January 1, 2018, to allow to say, instead of dictating what you have to do in a vertical program, we're going to ask you, especially in areas dealing with chronic disease, equity, other health issues, vulnerable populations, we are going to let you take your data and you decide on that how you want to reallocate your resources to do that. That means you're going to validate, not because you're going to have to be like everybody else, but because your data drives you to that decision making. So this empowers public health at a local level to say, in order to deal with this one, we're going to move resources from here to there. It's easy said, it's a bit harder to do. You also have to say for those, especially some of the more well-to-do people who may find those public health programs to be one of 3 choices they have, because we tend to go well with the middle and upper middle class group. They'll say, how come you're stopping that program? We like that program. You talk to them and saying, this is where we're going over here to there. And they'll say, that really does exist in our community? I think, okay, I understand. Cut our program, you need to be addressing that, because as a citizen of this community, I'm disappointed and I'm practically upset that that's going on in our community. And I'd like to hear back on that to see what you're going to do about that. So we're trying to empower public health at the local level to realign and go with that. That means build new relationships where they haven't had them. That means working with new community groups that maybe they weren't aware of, asking staff to go into different roles that they didn't do before in that line, and saying, well, it doesn't match a vertical historical column. The data supports it's only but necessary, only but important. That means some of our skill base of our local public health professionals who have already had the training actually can be utilized even better than in the past. So we want a continuing investment in that community base with that to try and work on our issues around so-called, and maybe they're misnomers and bad nomers, vulnerable populations, priority populations. We'll leave it to those saying there's community groups that they want to focus on and to build up that community infrastructure. And we're looking for, in the future, even more of that because our reports, while we give some examples, they're not meant to be the comprehensive list at all. They're just but a few. And I'm glad to say there's many others out there, but it's not ubiquitous throughout the province. So we have many people leading from behind, and I'm looking for a lot more leadership as we go forward in that area. And we want to be able to say from a provincial policy standpoint, how will we support them in this approach?
As a past public health staff, I applaud you for the new public health standards and giving the health units a bit more responsibility in terms of knowing what their community needs and wants and shifting the resources to there. And it also allows public health and even municipalities and city staff to look at, how are we doing things? Are we being, recipients? Or are we going to have the community lead the process and the solutions and the ideas? And it's shifting how we work together, and the whole community conversation piece and having conversations with the community. And I just want to, my kind of takeaway from having read the report is that this is complex community work, and no one person, no one organization can do it alone. We need to work together, to effectively, make shift and change and, decrease loneliness in our community.
Mhm.
So thank you